everyone, and welcome back to the first of our afternoon sessions. It gives me great pleasure to introduce our next panel, the role of digital in the transition to value-based care. Our moderator for today's session is Rabbie, Digital Solutions and Capability Development Leader at Boston Scientific. As always, please do try and ask as many questions as possible in the chat function, and I'll do my very best to ensure that they get answered. So without further ado, Gil, it is over to you.
Thanks, Becky. Hello, everyone. Welcome to the session. I'm Rabbie. I'm thrilled to be moderating this discussion on the role of digital in the transition to value-based care. I'm really excited to be joined by a truly superb panel of experts, which I will introduce in a moment. Maybe just to provide some context from my side, I lead Boston Scientific's value-based healthcare initiatives in the EMEA region, which involves working across all our customer-facing products, service, and solutions divisions, together with health economics, market access, and other teams. The intent really is to ensure that value-based healthcare as a concept is fully absorbed by all these teams and their activities, but moreover, to support Boston Scientific in becoming more prepared to address the markets we serve with clear value propositions that are fit for purpose. If I summarize maybe the last year plus of learning in one sentence, it would be all about understanding, clarifying, focusing the organization around what part we play as a healthcare organization in supporting the ecosystem overall in the bigger value-based healthcare puzzle. My core role is actually all about leading the deployment of beyond the device solutions to key customers, so mainly providers in Northern Europe. So these include advisory support programs and increasingly digitally enabled ones. So I'm really interested in the topic of today's discussion because I think it's a real crossroads between the value that digital can play as an enabler to driving value-based healthcare more widely. So I'd like to move on to our panel and hear what they have to say on all this. I'm sure you'll all agree the team here will bring a real breadth of experiences from both the US and UK system. We've got Mark Davies, who is the Chief Medical Officer of IBM Watson Health. We have Neve McKenna, the Chief Information Officer of NHS Resolution. Corbin Petro joins us from the US, CEO of Eleanor Health, and Tim Gronniger, also from the US, CEO of Caravan Health. It struck me all in our conversations prior to today that the four of you are true practitioners of value-based care, each in a different way. So why don't we kick off with a two-pronged ask of each of you. If you could first give us a bit of background on yourselves and your organizations, and then maybe provide some context on which part of the broader value-based care agenda you feel you're supporting in your organizations. Mark, maybe we could start with yourself.
Yeah, no, thanks for that, Gil. So as you say, I work for IBM and Watson Health. I cover Europe, Middle East and Africa. I'm a UK clinician by background. The exciting thing about this kind of point of inflection in history in the pandemic is it appears to have accelerated something that we have been talking about for a long time in value-based care. And in IBM, we are passionate about supporting the healthcare industry globally as it goes on this journey, which we believe to be highly predicated on actionable insights, highly predicated on the leverage of emergent technology, and critically dependent on our ability to kind of reframe, if you like, the engagement model that we have with patients and the public, and in many ways start to redefine the social contract of healthcare in the way that the pandemic has certainly accelerated. So yes, just a few thoughts from me to start us off.
Thanks, Mark. Neve, would you like to continue?
Sure. So very nice to be here. So Neve McKenna, I'm the CIO for NHS Resolution. NHS resolution, possibly a less well-known part of the NHS. We deal with claims and litigations against the NHS. So we sort of see the implications of when things don't go as expected. But as part of that, we have a really important safety and learning function, and that's to take the learnings from those claims and when things go wrong and disseminate that out so that things don't go wrong again in the future. And I think that's quite relevant in a value-based care conversation, because essentially what we're trying to do there is think about how we can best use the resources that we've got. And in any system, you know, single payer, be it multi-payer, whatever, you're trying to do the most effective use of the resources to achieve better outcomes. And so there's an awful lot of things that I think, you know, we can work together on, and I'm very keen in my role to bring, for example, better use of data and being able to use that data in a good way to provide evidence and support you know, improvement. So if we look at, you know, the what people call the unwanted variations in care, so if everyone had, you know, the standard of care that is in the best trust or hospital, we would not just save a lot of money, but we would actually give people better outcomes. And so actually I think using that data, being able to share that and share experiences and suggestions around what works and what works well is something that we're very keen to do.
Thanks, Neve. Corbin, why don't we move on to you?
Great, thank you. Really great to be here. Good morning from United States. My name is Corbin Petro. I'm the co-founder and CEO of Eleanor Health. I spent my career in healthcare, really with the focus on designing unique and value-based payment models, rethinking how we deliver healthcare to underserved populations, thinking differently about how we deliver care, whether that's in a clinical setting or out in the community and in the home, and then leveraging technology and data to really make it all happen. In my current role at Eleanor Health, we're rethinking how care and payment systems are delivered together for care around substance use disorder and mental health. So when we think about our model, it's very whole person oriented, it's data driven, and it's focused on delivering outcomes that include total cost of care risk for the populations who we serve. So we're not siloed in thinking of mental health and substance use disorder within the paradigm of just behavioral health. We really think broadly about the people who we serve, and we think broadly about the outcomes that we try to achieve, being, you know, whole person life outcomes as opposed to sort of process and siloed measures. Prior to Eleanor, I spent my career in the public and the private sector. So I spent some time in the US working for a senator, writing parts of the Affordable Care Act, which includes significant provisions to help move toward value-based care. I spent time as Chief Operating Officer of Medicaid in Massachusetts, and Medicaid's the public plan for lower income and disabled individuals. And so designed a number of payment models in that capacity that help to deliver higher value care to the underserved populations. And then prior to Eleanor, I ran a payer provider joint venture that included shifting a lot of risk to provider entities. And as part of that joint venture, we spun out a population health business, again, focused on facilitating the move to value.
Thanks, Corbin. It's great to have you. And Tim, finally, yourself.
Yeah, good morning. Glad to be here today. So I'm the CEO of Caravan Health. I've been in this role for 4 years. And before that, my background was also in healthcare financing and in the Affordable Care Act. I spent some time at the White House and the Centers for Medicare and Medicaid Services, standing up new payment models, underlying a lot of the value-based care financing mechanisms in the country right now. Caravan Health is an organization focused on helping providers implement value-based care in a variety of settings. And our focus is heavily on underserved providers, safety net providers, and rural providers. And we serve about 250 health systems, about 15,000 clinicians around the country in ACO, accountable care organization payment models, and other value-based care arrangements that are focused on reducing total cost of care and managing the quality of care that patients receive, significantly increasing the provision of preventive care, increasing provision of care management services for very high-risk patients. And our orientation around digital has always been around synthesizing a vast number of platforms that our clients use. We have interfaces with more than 60 EMRs around the country, from the worst version of an EMR that hasn't been updated since 2016 to the latest version of Epic and Cerner. So our focus is always on how these products are used in practical ways, with as little human drag, as little time spent on making the interface perfect, and more focus on practical ways to insert information into workflows that can be used to generate good operational, clinical, financial outcomes.
Fantastic. That's music to my ears, Tim. I'm looking forward to hearing more about that. So I guess before we touch on the digital component of today's theme, I want to maybe start with discussing a bit more the value-based care models themselves. And these need not be necessarily digitally based. And I'm interested in the panel's views here around what are the essential ingredients in your mind for effective value-based models, from the fully enabled ones, the kind of end-to-end outcome perspective, and even through to pockets of excellence that maybe you've observed in your careers to date. Why don't we start with Neve, maybe this time?
Sure, yeah. So, I mean, I think, we've touched on some of them already. I think data and evidence, really helps. Remember that so many clinicians are brought up with a very scientific mindset. So providing that evidence is really important, and sharing it. I think there's a big thing around transparency. If we look at, there's a program in the UK called the Getting It Right First Time, GIRFT program, where they're trying to, it was set up originally in orthopedics to kind of drive down, again, those unwarranted variations. A lot of that was just about sharing the data with each other, and so that everyone could kind of say, well, hang on a minute, if they're not getting if their readmission rates are half of mine, what are they doing that I'm not doing? So I think there's certainly an important element of transparency. And I think with that transparency comes culture. And that's, again, something we see in resolution in a very different context. But I think the culture around, it's not about blame. Right? So what we're trying to do is share information, share good practice. There's no finger pointing to say you're not doing a good job. We're just trying to get a culture of openness and sharing so that people can feel like, oh, great, I can take the good parts of that. No one's accusing me of not being a good doctor. They're just helping me understand how I can make things better. So I think those are some really important elements. I mean, there's many others as well, but I think that they're often ones we don't talk about in the context of sometimes the digital solutions. I think culture and transparency really important.
Absolutely. Thanks, Neve. Mark, I see you nodding there. Do you have some ideas to add?
Yeah, no, I strongly agree with that, and I might make a sort of fairly basic point to begin with, which is around language. So I see a lot of talk about value, a lot of talk about outcomes. But actually, those terms are used fairly inconsistently, and I think that's a problem. So for me, there are kind of, simplistically put, there are 4 elements to healthcare. There are inputs, there are process, there are outputs, and there are outcomes. And we are terrible at mixing up process and outputs with outcomes. So if you really want to get to a value-based system, which essentially is outcomes divided by cost, we need to be really explicit about understanding how we measure those outcomes in a way that makes sense for populations. So most of that is predicated on the data science of bringing together a longitudinal data architecture that is centered around individuals and in a population rather than centered around organizations, which is a sea change for many healthcare systems around the world, but is an important element of understanding need, understanding risk, understanding the characteristics of groups in an organization, in a population, in a way that you can measure the individual outcomes and indeed the individual patient experiences in those cohorts, which is so key to understanding value and using those insights to design systems and design services to better meet those populations. So for me, this really hinges on this interface between data science, insight, and design.
Thanks, Mark. Tim, Corbin, maybe on your views on the US side, models that are getting traction on your side of the pond?
Yeah, I obviously echo what's been said around use of data and analytics, looking at outcomes and really orienting around those as the foundations of value-based models. You know, I think as human beings, we're complex. We're not defined by specific conditions or diagnoses. And I think our healthcare system in the US and some of the payment models has siloed in on specific diagnoses. So in our space, in substance use disorder, 80% of people with a substance use disorder have a co-occurring psychiatric condition. 70% of them have a physical comorbidity that impacts their overall health. And so if you're thinking about those in separate silos, you're not taking care of the whole person. So I think to the extent that we can pull our outcomes to the whole person level, whether that's total cost of care, whether that's life and well-being, and obviously mortality and other outcomes that are focused on the whole person, the better off we'll be in designing models. I think some of the models in the US that I think are moving in the right direction, but miss some of these points and have unintended negative consequences are episodic payment models, where again, we're sort of siloed in on either an episode or a segment of a human being and their care. And I think there is real opportunity to abuse those. That said, I think less abuse of those than the fee-for-service structure that we have in the US. So moving in the right direction, but I always want to call out that there's opportunity to keep moving along the value continuum.
I agree with that. And I would underline 2 points in particular. I think in the US, we have this problem that's pervasive, that every provider has some 5 to 20 different significant payer and relationships that they need to manage. And some of them are significant in most contexts, like Medicare, and some of them are significant in some contexts, like a United Health Group relationship for a large public account. And then others are very small. And so the first point is that we need to have payment incentive alignment of a significant enough portion of a provider's business to make it worth investing in clinical resources, technology resources, something that's going to make a difference for the way they can take care of their patients. And that's achievable now more than it was 10 years ago, but it's still quite hard in many cases. The second part I would underline is cultural alignment, that payment alignment isn't enough. There needs to be a meeting of minds between the physician and clinical leadership of an organization and the administrative or the business leadership of an organization. And the most successful organizations can figure out the payment situation if they are aligned. If they are not, even if they're in a good payment environment for value-based care, they will generally fail.
Yeah, really good point, Tim. The alignment inside the organization is no less important than the system as a whole and all the complexity between the different components of the system. Great, some really fantastic points. So maybe if we move on to the digital perspective here. So Neve's already touched on the value of data, of course, and particularly the transparent sharing of it and the power that can have in just pushing the envelope on what makes better outcomes. I wonder if we could get more targeted now and think really about what are your perspectives around how data can play a role in identifying value, quantifying it, and really creating change that will support better outcomes and at lower costs. Should we start maybe with Corbin?
Yeah, absolutely. And I think data plays a huge component at the population level. Obviously, sort of stratifying and understanding the needs of various cohorts is critically important. But I also think capturing data at the point of care and using that data to ascertain different clinical interventions is really important to deliver efficient care in the right place. I think new technologies that do sort of remote assessments and checking in on patients so that they can capture when a patient is at a tipping point of having a significant event and intervening are really important technologies that we can introduce for certain populations that are higher risk than others. I think other technologies that are really sort of engaging members when they are maybe in a lower acuity state so that we can utilize our resources effectively is another great use of technology to, again, think efficiently about how we're using technology. So I think the role, I think we've come so far in the use of data, especially as it pertains to creating value within the healthcare system. So I think data and monitoring and use of various tech platforms and being smart about how you leverage those across the ecosystem is, where I see the most impact right now.
Thanks, Corbin. Mark, IBM Watson is clearly data at its very core, digital. What do you think from that perspective?
Yeah, so I might provocatively say that one of the problems that I've seen in my career in health data is it produces really interesting insights. And interesting insights don't change behavior and they don't help patients. They don't save lives. So I think there's something really important about this phrase actionable, that we use data and link it very clearly to what colleagues have been talking about around learning systems. So understanding the impact of our interventions and creating loops that allow us to understand variance from perhaps current evidence and what the outcomes are, and creating systems, closed learning systems feels like a really important opportunity. We have had a history, I think, in healthcare, unlike other industries, of being somewhat dominated by descriptive analytics. We are starting to embark on the world of predictive analytics and modeling analytics, and using some of the kind of techniques that have been enjoyed by other industries, such as the insurance and marketeering industries, to start to better understand the modeling of the future. But one of the areas that IBM is particularly interested in is the whole area of augmented decision making. So Neve talked about the kind of unexplained variation of care, and there are a number of reasons for that. But one is the requirement of healthcare professionals to process and remember completely unrealistic amounts of data, information, best practice, and evidence at the point of care every day. And actually, I think we have reached the point where actually we need augmented professionals using emergent technologies like artificial intelligence to actually do some of the heavy lifting of presenting evidence to support decision making, to make them more consistent, higher quality, and ultimately safer. So I think there is an enormous area of opportunities of the involvement of modern data science techniques into the direct provision of care. The other area I might just touch on is public engagement. So we have, if we look to some of the sophistication of how people market to us or how people advertise to us, and we compare that with, say, a health promotion or a screening program about how we attempt to engage with those populations, they could not be further apart. So there is an awful lot of data science capability that we can draw down from other industries and apply to creating, if you like, a frictionless interface between citizens and the health service, which is such a key part in empowering people to take increasing control over their own health.
Thanks, Mark. Tim, did you have anything to add?
I would add that we are all awash in data at all levels of the healthcare system at this point, and it's great that we now have access to far more than we ever did. And it's still, in many contexts in the U.S., there's still not complete access to comprehensive information about even basic claims. There is in ACO payment models in general, and I would say now 20% of providers probably can access that information on demand, whereas before it was zero. Hopefully, it'll be 50% in the next 5 years. But it's really important to focus on getting the insights out of that data at points that are useful for physicians and health systems that are completely overwhelmed in their day jobs, and that's part of our job as an organization serving them. Distill what we know from what's worked in other places similar to our clients and similar to their settings, whether it's a rural setting or an urban setting or for certain types of patients, and distilling it for what's useful for someone who's running an organization at a network level versus someone who's working at the clinic level, identifying gaps in care that can be used to intervene at that moment, or identifying patients at high risk of adverse outcomes in the next month. So that's where there continues to be a lot of work and innovation, and I think that we're going to see over the next few years that type of information become much more commodified and much more readily available to everyone in the U.S. context, at least.
Thanks, Neve. Anything you'd like to add?
I think the only sort of point I'd add to it is I think we're all kind of agreed data is really important. We need to use more of it, get it timely. I absolutely agree with it's more than a human can process, and we need to supplement that human thinking with help to process that data. I think the other sort of really important point is we underestimate how connected our data is. In the NHS, people often talk about, we've got this amazing longitudinal data set, it's unique in the world, but it's actually really hard to get hold of, and it's actually not that easy, and the data isn't that connected. And then Tim's just touched on some of those problems. But I think, almost layered on top of that is the fact that today we realize there are so many more data points that are relevant to your health outcomes than are captured in an EMR. So, that social determinants of health, which is around your income and your the kind of job that you do and the conditions in which you live and all of that sort of stuff, that's all actually relevant data too. And I know Corbin can talk very eloquently about the work that they do, which is treating the whole person. And so it's not even just a question of processing the data that we have in our systems, it's all the data we don't have, which is actually also really relevant in a value-based model, because all of that is going to help us get to that better outcomes.
Absolutely. So I hear a big theme from you all around the overwhelming nature almost of the data that's out there, the need to sift between the interesting insights and the important outcome changing ones. There's a lot of noise in the system, clearly, and taking it to a point where it can become a practical application and really change the way we work, change the workflows and change the pathways is, I think, the vision. I'm wondering if you've got anyone really open question to the panel here about whether you've got some particular examples that you can point to of where systems or even point providers have managed to cut through that noise and effective change in a way that's really reconfigured services or even plans for interventions based on sound data evidence that's cut through the status quo or the standard of care or the perceived wisdom before. So open point, really, whoever wants to chime in.
Gil, I'll just pick an example from some time ago, if that's okay, from London in the UK. And It's around the kind of reconfiguration of stroke services in the capital that was about 10 years ago. So we had a number of national stroke audits that went on, which were very high caliber audits, internationally recognized, and there was a growing body of evidence around the value of hyperacute stroke services for thrombolytics. But obviously that required, not all the hospitals in London having a stroke service, and they had to be rationalised around these hyperacute centres. And of course, everyone in these hospitals wanted to defend their own patch, and it became very political as populations wanted to defend their own patch. We had a lot of politicians involved who were kind of defending the status quo and getting a lot of popularity around it, and it became really, really difficult. And the expression that you used around a laser-like focus on outcomes cutting through all that noise was exactly what happened. So because of the audits, we understood very clearly what the outcomes were for strokes in London, which was not good. But at that time, London was indeed had some of the worst outcomes in terms of mortality in Europe from strokes. And due to, I would say, some visionary leadership by a number of individuals in London, that narrative around a focus around outcomes managed to win the day in a very heated discussion. The system reform happened, they rationalised on hyperacute units, and London moved from one of the worst places in the world to have a stroke to one of the best, and has some of the best outcomes now across Europe in terms of stroke mortality. So that I think is a very clear message around the power of a focus of outcomes. But before Corbin says it, which I suspect she's dying to, that's all well and good. But wouldn't it be great if we can move the next stage and make London one of the best places in Europe not to have a stroke in the first place? And that's the challenge before us now, to start thinking about those broader determinants of care and start embracing the same principles of a focus on outcomes, not just on redefining clinical process, but starting to think about health in that more inclusive way.
Yeah, I was thinking about some of the previous comments around, data and analytics and how it's used. Tim said we're awash with data, and I remember when population health and that term sort of emerged 5 and 10 years ago, that organizations thought, oh, population health, let me buy an analytics tool. And so they bought the analytics tool, they got all their data into it, and the analytics tool was ready with all the data, and then they didn't use it at all. Because there wasn't anyone there who was pulling out the insights, thinking specifically maybe about stroke care, thinking specifically about how to prevent stroke care, thinking really holistically about what that data was telling us. And I think we're moving into the phase where we're starting to use that data, both at the aggregate level, where we're identifying new ways of delivering care and ways to identify populations, but also at the point of care. But I think we're so far from being there with actually using the data in an effective way at the site of care and sort of intervening with patients using that data. Really, I think you said, Mark, augmenting decision-making. So using sort of decision support, using it at the site of care. I feel like the organizations that are doing that are in the 1-2%. Really, that's just not how care is delivered still. So I think there's just so much movement either to layer on the healthcare organization pieces that are really addressing what the data is telling us, or continuing to move the needle on having organizations and having providers use the data at the point of care. I wanted to highlight that, because I feel we're sort of wonky and talking about value-based care and data and analytics, but like the on the ground use of it, I still think is pretty limited.
Sure, and I maybe add a slightly different angle on this, which is, one of the schemes that we run in NHS Resolution is around maternity. Clearly, things that happen when things go wrong in maternity, it can have a catastrophic impact on not just individuals' lives, but then can be very costly to the health system. In the UK in particular, any money that is spent on resolving claims is money taken away from actual direct patient care. So NHS Resolution run this maternity incentive scheme where, again, we're trying to promote people, using data to say, look, if you take these actions which, we know improve safety overall, then what we can do is essentially reduce the cost of, the insurance type policy that you have to pay to us, because we know that these things, if you're compliant with these, key safety actions, then we know that means you're less likely to have impacts on births and things that will end up turning into claims. So there's lots of different ways in which you can kind of use this and use these measures. But I think, again, you can kind of sit there and say, well, actually, rather than just trying to address the claim, try and move back and say, let's stop that from happening in the first place, and what are the things that we can do to help do that. And that's it's a relatively new scheme. It's only been going for a few years, but early indications are that this is good.
That's a good example. I'll offer one additional example drawn from our work and that of some others. So one staple of ACOs in the Medicare context in the U.S. is almost everyone who runs a Medicare accountable care organization spends a lot of time building a preventive workflow that relies on bringing a lot of Medicare patients in for annual wellness visits. And it's justified in that population because there is such an extent of high needs that are generally unidentified. And but a lot of studies found that there were not a huge impact of those increases in wellness visits on downstream events like hospitalizations and progression of high risk disease. We looked deeper into this with some of our clients, and you can see in some contexts, in some cases, you would see a significant impact, in others you wouldn't. And digging deeper, able to find in a couple of A/B comparison groups, the groups that were running sort of low impact wellness visits were heavily MD focused. And it wasn't that the physicians don't know how to do this. It's that a good wellness visit takes 45 minutes and physicians don't have that amount of time to spend with any given patient in front of them. The effective ones were being staffed primarily by nurses and by medical assistants, dividing up time efficiently, which is something that we had been coaching to because of the economics of it. It made more sense, but it also results in much higher clinical quality metrics, meeting the requirements of the visits, making sure you get depression screening done, making sure you get that you discuss the health risk assessment. And so looking at sort of an aggregate issue with a major preventive workflow, and then digging into the real world, how it works in a practice in the rural Southeast, can lead you to some useful insights that you can then spread in other parts of the country as well.
Thanks. Yeah, I think some really great examples there, and just goes to show how I think value-based healthcare is still manifesting itself in such different ways that can all make an impact, and digital plays a big part. I'm conscious we're getting close to time. I want to take one question that's come in from the audience. The question is around common mistakes that companies see, or companies may make, in making their digital transition. Wondering if the panel has any thoughts around common pitfalls to watch out for in the context of trying to demonstrate value when integrating digital components into doing that.
I'll be brief and jump into that, Gil. I think one of the problems that really bedevils this world is bright, shiny things. New bits of technology that can kind of dazzle and look really, really, really impressive. It is so important to see this as a design enterprise. It's about service transformation, and digital capability can offer us a great deal in that. But fundamentally, this isn't about digital. This is about service transformation and starting and ending with the impacts that you're trying to achieve. So Tim's example around behavioural change and the kind of rocket science discovery that specialists in behavioural change probably get better outcomes than doctors who aren't, is a really good example of that. Let's start with what we're trying to achieve and take a user-based design approach, philosophy to changing, and then drawing in digital capability, whether that be analytics, whether that's AI, whether that's devices around that. The other thing I'd say very briefly is we can in healthcare be quite arrogant and think we need to do everything ourselves, but to the point that has been made already, only 15% of the outcomes that we see in our populations are dictated by clinical care. The other 85% are defined by the environment that we operate in, our employment, our significant friends, our communities, etc. So there is an enormous trend at the moment in certainly in the UK and other parts of Europe to start using those assets in communities to help people to take more responsibility around their health and well-being, and using digital platforms to connect people like me and to create digital connections and digital communities to support those kind of endeavors. So we don't need to do everything ourselves. It's about doing it with communities, not to communities.
Yeah, I couldn't agree more. I think the proms and the prems that are increasingly coming out there need to be seen as the enabler of the outcome, as opposed to the value in and of itself. Sorry, was this on the other point?
Yeah, I was just going to say, I think that which is the age-old adage, you get what you measure. I think, with any transformation, you've just got to be mindful about what you're actually measuring, and therefore, particularly in an area like this, as we just, as Mark just said, so much of our health outcomes are determined by things that are not, necessarily a clinical intervention. We just need to be careful, because those measurements can be quite binary. They can be measuring of outputs, not necessarily outcomes. The outcomes can be very broad indeed, and can be very long in nature before they actually manifest. And so it's actually quite tempting when you embark on a transformation program. Everyone wants to go, well, when is the benefits? What's the benefits realization plan? When am I going to see the return on this investment? I don't have a magic bullet here. I just say, spend good time thinking about that and being very realistic about what you can measure, what you will measure, what will get you what you want, and will it drive towards the right outcomes.
Yeah, I think the biggest mistake I see by far, a combination of what Mark and Corbin said, that embarking on a value-based care plan for many providers is buying an analytics platform and then clicking around inside the cool modules and looking at the nice Tableau reports and being intrigued by what's happening in your system, and then thinking about it, identifying problems, but then not really having a plan or resource strategy to actually effectuate any changes. And that's the consistent theme of this panel. I think that I've heard of connecting data to workflow changes to practice changes is the way forward. But very often that planning doesn't happen up front.
I think I would just add that, I think technology and data is part of the solution. It's been 43 minutes. We haven't mentioned COVID, so I'm going to do it. I'm going to mention COVID. So we're in this environment of a pandemic, and everyone's gotten really excited about the move from sort of in-person care to virtual care. At my organization, we went from 10% virtual to 90% virtual basically in 3 days. That's really exciting. It doesn't mean that we don't need to deliver in-person care anymore. So I think understanding the role of technology as it fits into the organization and the place and the time that you are existing in is important, and not to make huge leaps on changes in patient behavior, changes in provider behavior, before really sort of taking the whole and the comprehensive model into consideration.
Thanks. Yeah, Corbin, I had a personal internal challenge to see if we could steer away from COVID in some way or shape or form. And you beat me there. But no, that it can't be ignored. But maybe to close really as we're rounding up, and maybe in a word or sentence, if you like, looking ahead, right, 2021, short term, what is the one thing that each of you would like to see as a tangible, practical change that maybe takes place to move this value-based agenda forward from your own perspectives? Tim, maybe let's start with you.
Well, taking as a given that solving the pandemic would be all of our first choice in this. After that, to move forward on value-based care, and thinking about what the new administration and Congress can do in the U.S. context, I think that there's a tremendous amount to be done. Back to the first thing I started with, of getting payment incentives correct in Medicare and also with major commercial payers. We've done a lot of work on that, but I'd say we're only about a third of the way there. So that would be my request of policymakers in the U.S. right now.
Now, I'll piggyback on that because you sort of took the angle I was going for, Tim. In the U.S., so much of value is driven by what comes out of CMS, which provides guidance and models for Medicare and Medicaid, which are the largest populations and the highest cost populations in the country. And so I think the biggest thing that we can always do is have an administration that's moving those models forward, moving payment models, moving process and outcome measures forward, because that's where we see the most impact broadly across healthcare.
Gil, this is going to be the most boring question you've asked, because I'm going to say exactly the same thing. I couldn't agree more with Tim and Corbin. It's this system alignment thing is so important, we see it right across Europe. So we see it in the UK, and it's about anatomical alignment. So thinking about the organisations, and we are hopefully going to see some integrated care systems being put on a statutory footing in the UK that will have responsibility for this over the next year or so. But in other parts of Europe, we're seeing similar initiatives. So anatomical alignment is really important, and then the kind of the financial, but also the regulatory and indeed the licensing alignment. So for professionals and for organisations, and of course the flow of money. So getting those all those things lined up along the direction of value, I think has become less of a nice theoretical conversation. I actually think it's now, I'm sorry, I'm going to use the COVID expression, it's now become an operational imperative. This is how we dig ourselves out of the current hole that we are in healthcare, and that's what we need to do.
And I suppose to sort of maybe build on that is, I think the thing we really need to do is have a very grown-up conversation with people, the population at large, about all of this. And that's something that I think governments sometimes find it difficult and are a bit scared to do. I think that includes a grown-up conversation about data and how your data gets used, and I think being able to articulate this in a way that makes sense to people, so that people can understand. It's back to that transparency point. People need to understand what those decisions are that we're going to make, why we're making them, because otherwise what happens is they get made, no one really understands it, and then you get a cause célèbre that comes out and someone goes, oh, why have you withdrawn care for this or that? And it's like, no, this is all part of a much broader, balanced decision that we're taking. So I think engaging everybody on this journey is really important.
Thanks, Neve, and thanks, everyone. I think we're all in violent agreement there. And on that note, I just want to thank you all. I think there's been some really rich observations and ideas coming out of this group, and it's been a pleasure to moderate the panel. Thank you all very much. Becky, over to you.
Thanks so much, Gil, and thank you, as you've said, to all of the panelists that have participated today. some great insights and definitely some food for thought, which is certainly I know I'm going to take away. So on to our next session in a mere sort of 10 minutes. We'll be in discussion with healthcare's new entrants, which includes Magic Leap, Twitter, and Lululemon. So if you find out what they're getting up to, do tune in. But until then, thank you again to the panelists, and I will see you all in a short while.